Hello, everyone. Thank you so much for joining us for our July webinar. Our topic today is suicide prevention with deaf individuals, why traditional models can fall short. For those of you that have attended before, you'll know me, and for our new faces, welcome. I'm Emily. I'm our communications coordinator here at OSPF, and I have the privilege of hosting our presentation today. Before I hand it over to our experts, I would like to do a few housekeeping items. So after today's webinar, there's going to be an email that's going to come to each of you. It's a follow-up recap email, and it's going to have a bunch of links in it. There will be links to the resources, the slides will be included, we'll have a recording of the webinar included. But most importantly, there is going to be a post-webinar survey in that email. That survey is going to be required for anyone who wants to receive CE credits or a certificate of attendance. So please be sure to complete that by July 20th, which is a week from today. CE credits are only available to our OSPF members, but anyone can receive that certificate of attendance. I'm also going to include a link in that email. If you would like to join and become a member, it'll show you how you can do that. And as a reminder, all certificates will be sent within 30 days. At the end of today's presentation and throughout, we're going to have some time for Q&A. So if you have any questions, please feel free to put them in the Q&A feature, and I will moderate that, keep track of that, and share those with our presenters. If we run out of time and don't get to all of the questions, I will also include our presenters' email addresses so you can follow up one-on-one after if you would like. All right, without further ado, I'd like to introduce our speakers. Before I do so, we also have a ALS interpreter, Casey, with us today. So Casey, thank you for being here. All right, let's start with Maria. Dr. Maria O'Neill Ruddick is the director of the Mental Health and Deafness Project funded by DBH, where she trains mental health professionals to work effectively and culturally responsively with deaf and hard of hearing individuals. She has over 40 years of experience serving the deaf community. Previously, Dr. O'Neill Ruddick served as the director of Community Center for the Deaf and Hard of Hearing for the Cleveland Hearing and Speech Center. She is also a key contributor to the project funded by the Office of Violence Against Women in collaboration with the Cleveland Rape Crisis Center, examining the prevalence and impact of domestic and sexual violence within the deaf community. Currently, she works as the community engagement and advocacy consultant, providing education, outreach, consulting, and training to social service agencies, healthcare providers, and businesses throughout Northeast Ohio. Maria, thank you for being here. Next, we have Vince Sabino. He is the Associate Director of the Mental Health Recovery Board for Licking and Knox counties in Ohio, where he oversees the clinical and fiscal operations of the behavioral health system of care. With more than 25 years of experience in community mental health and addiction services, Vince has worked extensively with individuals experiencing severe and persistent mental illness, substance use disorder, homelessness, criminal justice involvement, and the unique needs of the deaf and hard of hearing population. Throughout his career, he has held leadership positions with the Adams Board of Franklin County and Elvis, where he has directed innovative behavioral and recovery initiatives, including opioid response programs, crisis services, recovery support, and treatment programs for vulnerable populations. Vince has also contributed to the development of crisis care continuum across multiple Ohio communities. And last but not least, we have Dr. Jerry Hayes, a licensed clinical psychologist with over 25 years of experience providing mental health and services across clinical, academic, and community settings. He specializes in culturally responsive care with expertise in working with deaf and hard of hearing individuals and interpreter-mediated therapy. Dr. Hayes currently practices psychotherapy through both telehealth and in-person settings. In addition to his clinical work, Dr. Hayes has extensive experience in program development, training, and leadership. He previously served as the director of the Counseling Center at Notre Dame College and the assistant director and training director at Baldwin Wallace University, where he supervised doctoral and master's level trainees and developed campus-wide mental health initiatives. Dr. Hayes is actively involved in advancing deaf behavioral health through his work with the Cleveland Hearing and Speech Center and the Deaf Behavioral Health Collaborative, where he co-develops and delivers statewide trainings for clinicians and interpreters. He is also the developer of the Changes Model, a practical framework designed to guide clinicians in supporting meaningful change. Maria, Vince, Jerry, thank you so much for being here today and for presenting. You are able to take it away whenever you're ready.
Thank you, Emily. We're so happy to be here today. Welcome, everyone. You know who our team is today. We actually have our Deaf Behavioral Health Collaborative isn't actually a larger team, but you have an abbreviated team today of the three of us. We're so happy to be here. Let me just kind of get started on a few little things that we want to kind of frame for you all today. And that is that suicide prevention is not only a clinical issue, but it's also an access equity issue. particularly when working with deaf individuals. You may be familiar with a lot of other standard suicide prevention models. For example, this is not a QPR training, and we will not be teaching the formal kind of question, persuade, refer model. Instead, we're going to focus on how suicide prevention, assessment, and crisis response needs to be adapted when you're working with deaf individuals. So that's kind of our focus. It's a practical training rather than academic review of or intervention. The goal is to help you understand why hearing-centered prevention models can miss risk, can weaken rapport, and produce false reassurance, right? So we hope to offer some concrete ways to improve assessment, safety planning, crisis response, and systems design. So one of the things I just want to point out today, and that is that we're a blended team of hearing and deaf professionals. That is by design. We work collaboratively with one another, but as a blended team of deaf and hearing professionals, we use ASL interpretation for complete access for both presenters as well as for attendees. When you've met one deaf person, you've only met one. And deaf individuals use different modes of communication to access and provide information to individuals. So you might notice, for example, a slight lag between either the speaker and or the signer, and that can happen sometimes in either direction. But okay, so let's talk about why this is important. Hold on a second. Okay, so as we go through, there's a lot of information on the slides. For those individuals on the webinar today who might themselves be deaf, hopefully you will have an opportunity to look through the information in the slide, which is a lot. And I'll kind of give a little recap. So it's not that there's an absence of services. It's actually an absence of equally effective services when it comes to deaf individuals. So hearing-centered systems, those that just check the box for access will still fail in providing communication that is nuanced enough for mental health and suicide prevention work. In suicide prevention, communication is not peripheral care, it's care. And so it's really, really essential that you pay attention today to issues of communication. It's really a lifeline to the work. Okay, so let's talk about deafness is not a risk. So Jerry?
Yep. Hey, hi everybody. Thanks for joining.
I'm not seeing you.
Oh, hold on.
Nope, you're good. Let me pin him really quick.
Oh,
okay.
And there we go.
Okay, great. So the key message again is that deafness itself is not the suicide risk. The risk comes from the barriers that accumulate over time. Things like language barriers, they can limit direct communication, incidental learning, and access to information about emotions, mental health, and even available support. Social isolation may occur when a deaf person is excluded from things like family conversations, which is not uncommon, or they don't share, the family doesn't share full accessible language with each other. Trauma caused by things like autism, discrimination, bullying, abuse, and ongoing stress of just navigating inaccessible environments can further increase emotional distress. So when we think about mental health and crisis systems, they're often designed around hearing norms, such as telephone access, rapid spoken communication, English-based assessment tools. This mismatch really can lead to missed warning signs, which are so important in suicide prevention, as we know, inaccurate diagnoses, or someone being labeled uncooperative when communication access was the real problem. It wasn't that they were not trying to cooperate. When these barriers multiply, as you could probably imagine, distress just increases, access to support decreases, and interventions actually may come too late, unfortunately. Suicide prevention, therefore, requires us to reduce environmental and system barriers, not view deafness or deaf identity itself as the problem. Vince, go ahead.
All right, so I'm just gonna wait for me to get pinned. And just as we were, some of the Q&As that have already come in, about being able to see the interpreter. So you should be able to see Casey as our interpreter. And also would just like to mention that the captioning feature also works. So as a deaf member of of this troop, I am happy to see everybody. So we want to talk about what were traditional prevention models assume hearing norms. So traditional prevention models often treat spoken disclosure as the clearest sign of risk, assume that calling a hotline is the natural way to seek help. And it relies heavily on written English. So they may expect a deaf person to adapt to the service rather than the service adapting to the person. So the opposite. So a deaf responsive approach begin by identifying person's preferred communication method, language fluency, and access need before judging their engagement or insight. It also provides several ways to get help, including video phone, text, relay services, chat, and trusted community supports. Safety planning and education should be visual, concrete, and culturally relevant. Language access, trust, and deaf cultural context are not extras. They are central to the effective suicide prevention. So communication access isn't simply a courtesy or accommodation. It's an essential component to care. So as I always like to say, when I have an interpreter for me, the interpreter isn't necessarily for me. It's for the hearing person as well. So that is that exchange, and that's why it's not just for me, it's for us. So in mental health and suicide assessment, the interaction itself is part of the intervention. If the provider cannot accurately understand the person's meaning, the assessment may be incomplete or even worse, misleading. So whenever possible, direct services and person-preferred languages is ideal. When that's not available, a qualified interpreter with appropriate mental health experience may be necessary. Written notes, family members, or poor quality BRI may be sufficient for a simple exchange, but not adequate for discussing trauma, diagnosis, safety, or suicidal thoughts. The bottom line is very simple. If the communication is weak, the assessment will be weak.
Vince, can I just ask a
Sure.
question? So when you're talking about communication and you as a deaf individual are using a very clear speaking voice,
Mm-hmm.
can you describe to our audience what they might encounter that might be different for you
Mm-hmm.
versus for someone else who is deaf? Maybe just one or two brief examples. Also, not only your voice, but also perhaps your understanding of English versus your use of American Sign Language.
Sure. So so in the community, I'm considered to be what's called hard of hearing. So that allows me to, I can use my voice and I can sign. I can code switch pretty freely, where I can sign um, and I can speak for myself, which is not the norm. A lot of my friends and a lot of my colleagues either have one method or the other. And so as Maria said, when you met one deaf person, you've only met one deaf person. Now, for the purposes of this training, I elected to speak because we have an interpreter, and we wanted to see the interaction between, the audience, and myself as a deaf person. So in this instance, Casey is communicating for me in sign language, but typically I normally communicate for myself. So, that's the difference. And the second thing I think for me is, because I'm able to talk, we have to remember the environment in which I am in. I'm in a room, although you can't see it. I have four walls. The lighting is great. There's no competing sound. But as soon as I take 5 steps outside and I have the traffic, ambient noise, I don't hear as well. So in a crisis situation, my even just taking 5 steps to go outside completely changes my ability to interact and communicate with people. So that changes as I'm going to the store, and so for me, it's much harder because I constantly have to switch back and forth. Being able to be in an environment where it's nice and quiet and I have captioning, I have an interpreter. Whereas if I'm out in the community, I don't do as well. And it's just as simple as 5 steps outside that door. Does that answer your question, Maria?
Thank you very much, Vince. I
Sure.
just wanted people to have a sense of what they might encounter, and it may not, and likely in a
Mhm.
crisis situation, it's not going to be someone like you. Could
Mhm.
be, but
Could be.
likely not.
Well,
And
and
that's kind of the focus of us for us today.
mhm,
It's people who, like you were saying, use one or the other. You use both.
mhm,
If you're interacting with another deaf person who uses ASL, as I would as well, I will turn my voice off and I will just sign. Unless there are other hearing people around, I wouldn't want to be rude to them, but I would just sign. And why do we do that is because ASL and English are different languages. And so we're going to use one or the other. As Vince said, he's electing today to use his voice and to allow Casey to sign for him. But oftentimes he will sign for himself. Okay, thank you. That's helpful. Well, I know that Jerry, you'll move on to our next topic.
Yeah, so this slide highlights 4 ways suicide risk can be missed during an assessment. First, short or concrete answers may reflect a language mismatch, not poor insight or low motivation or even resistance. It's important to understand that. Second, literacy does not necessarily equal comprehension. Written English forms, safety plans, and clinical terms may not be fully accessible to someone whose primary language is an ASL. That's ASL is their first language, English is their second, and it's understandable that anybody with a second language may not be as fluent or with that second language, and this is the case, and sometimes we don't think about it that way. Third, language deprivation. And we're going to throw around a lot of terms because it's such a short session today that we'll at the very end we'll talk about some of our trainings that you can join later in this year and next year that will go over so much in more detail than what we're able to do today. But again, third, language deprivation, limited emotional vocabulary or atypical signing may be mistaken for a thought disorder, evasiveness, cognitive impairment, things like that. We need to understand the person's language history before interpreting communication differences as psychopathology. Really critical in this context, especially. Finally, we shouldn't accept a no too quickly. A negative answer may reflect an abstract, unfamiliar, or misunderstood question rather than a true absence of suicidal ideation or suicidal thoughts. That's as critical as it gets. A lot of times, a deaf person may not understand, but they'll just nod their head, or they'll say no to something when we just haven't assessed their language, and that's really the big takeaway. So before interpreting the answer, make sure the question and communication process were truly understood. Take it away, Marie and Vince.
Okay, so Vince and I are going to talk about kind of some of these, the issues involved when you're using interpreters for making an assessment. Today, of course, we have a live interpreter, but in crisis situations, very often you're going to have to rely on video remote interpreting. And that is just what we're talking about. It's remote. It's not someone local in the community. It's on a screen. which can present its fair share of difficulties, which we're going to kind of briefly touch on. But let me just kind of, and Vince, maybe in a second you can talk about how that works. But what we're hoping that you'll take away from today is that when you are working with someone of remote interpreter on a screen, you still want to be able to do a couple of things kind of what we call pre-session or before you're getting involved with the person. You want to make sure that there's an internet connection. You want to make sure that the equipment is working, that the cameras is on the deaf person, that there's proper lighting, that the person has access to the screen. So a screen can be up here, but if the person is prone and lying down, they're not going to be able to see that screen. So Vince was talking about himself when he goes to a different environment, he's paying attention to a lot of stuff. Where are people? Where is the lighting? Right? You have to do the same thing. You have to be paying attention to those things and make sure that all of those things are in place. So Vince, what do you think about once you're in the session with doing an assessment of this person? What does a person need to be paying attention to?
Sure. So I really like this picture a lot. However, there's a couple things I just kind of want to note. So first is, making sure as you're speaking that you're checking in to look at the monitor, which I think this lady in the blue is doing. And they both, but for me as a deaf person, when I'm communicating, I like being looked at. So making sure that we have that dialogue so that I know that you're paying attention to me and so on. But in this picture, I would say this is a great view to make sure that the nurse, the doctor, whatever role that the lady in blue plays is making sure that the screen is not glitching or it's that it's not freezing or that they're poor quality control. But once that's checked and that's good to go, I prefer to have eye contact and be able to make sure things are communications happening. And then also just, wanting to, pause, maybe troubleshoot, or switch to an alternative communication should something go wrong. And then consider whether or not an on-site interpreter should be needed. So really, as you're in this picture, does a really good job of just making sure that that the nurse or doctor in this picture is making sure that things are in flow, but when that's confirmed and things are going well, making sure you maintain eye contact.
Just as a couple of quick things, you want to make sure that as Vince was saying, if you need an on-site interpreter, if communication is not working, you're going to need an on-site interpreter, a live interpreter. And sometimes that is hard for you as a first-time, perhaps, person when you're doing this to be able to determine. But if there's a lot of misunderstandings, you're noticing the person's facial expressions. Again, your job is to be checking all the time between the interpreter as well as the client, that you're checking their understanding. You might want to be asking for some follow-up questions to make sure that they are understanding the concept that you're asking. And you want to make sure that you're documenting and following up on all of that. You want to make sure that you're confirming that accessibility resource, did it really work? Not just checking the box, I did this, I got this, I'm following the law, I'm getting an interpreter. If the interpreter and the client are not working, then your assessment isn't working. So effective communication is much more important, obviously, probably can get this, than just getting the interview finished as quickly as possible.
And I would also just mention that, sometimes in ER, EDs, sometimes there is, the Wi-Fi doesn't work as well. Sometimes there have firewalls or what have you. So even just getting a signal sometimes can be problematic because it's not technically on the network. So you just want to make sure that you have all that checked. A really good live example, Maria and Jerry and I really haven't had a chance to talk about it, but there's an episode or a TV show called Pitt, and it's on HBO, and it's a TV show about an emergency room over the course of a shift. So it's 12 hours broken up in 1 hour segments. But there's a part where there's a deaf person and they're waiting for the VRI and having to wait for hours upon hours because the equipment wasn't working. And that's a really good way of, if you ever get a free moment, that's a real, they did a really nice job showing just the frustration of bad technology in an emergency room setting.
So now let's think about adapting the prevention strategy. So we're talked a lot about the initial piece of just the initial assessment. Oh, thank you, Emily, for putting that in the chat. So this is where we kind of move from describing some of the challenges in actual ways to approach working with the individual. This is the point, it's not to invent something completely new, not a whole new suicide prevention model, but rather making sure the prevention strategy is understandable, that it's culturally responsive, and is usable under stress. Tough, maybe tough sometimes to figure that out. And again, I want to just kind of highlight, we can talk in other trainings in the future that are much more in depth in terms of determining understanding and comprehension when you're working with a patient that may be have compromised use of language as a result of trauma and or just as a result of what we call language disfluency or language deprivation syndrome. Being really concrete, right, Vince? Being concrete is very, very important. I think even if you want to err, you don't know this deaf person, you don't want to talk down to that deaf person, but you are doing an assessment, you are then coming up with prevention strategies. You want to make sure it's understandable. You might want to err on the more concrete versus more abstract, so that you're providing really good information in concrete steps. Not abstract terms, not assuming that person understands what you're talking about, but making it usable. It can often help when you pair words with examples. So things like things that are visual, things that are happening in their body. A safety plan should not just also assume that the person can call someone or use a telephone, or have access to hearing family members, because very often hearing family members don't sign, and they may not have a connection with a hearing family member because of that. So kind of imagine creating a safety plan that works for a deaf client, that has limited trust, and inconsistent family interaction. That can be very typical for some of the clients, certainly that we serve, that their connection with their family might not be solid. Other things that I might have forgotten, maybe an example, Vince?
Yeah, I mean, instead of using text-heavy safety plan that says, call someone if symptoms worsen, we would maybe create like a one-page that's more visual in nature, that has a few clear steps. So, maybe like first would be identify specific warning signs, and obviously that's different from person to person, deaf person to deaf person, hearing person to hearing person. Maybe name two people that person trusts. And then maybe write that down. I trust, in this situation, I trust Maria and Jerry. And so I would want to have their names as part of that. So that's visual. We can see that. And then list accessible options such as, a 988 video phone. We're going to talk a little bit about Deaf Lead a little bit later on, but making sure that the deaf person knows about Deaf Lead. They can still use 988 through their own video phone, either through text or chat. Now, identify a safe place to go in case the risk increases. So I might I might draw a picture of like a house, right? And it's like the safe place and identify where that safe place is. It could be my friend's house that I trust. Maybe it's my family member's house that I can go to. That when things are getting troublesome for me, I have a place that I can go to that's visual. And even if we write it in, grandma's house, that is a good still visual. So again, try to be as much very visual as much as possible. And then making sure that the person, as you start to, identify the safety plan, that we go through and understand, and maybe even have them repeat back to you. So who are the two people that you trust? Maria and Jerry. Well, where's the safe place you can go on the house? Well, that's grandma's, or that's my friend's house. So again, just better than just do you understand?
So another key component for all of you to be thinking about is very often you're going to get information about the person in crisis that you're going to know in advance. Not always, but most of the time you're going to know in advance that the person is deaf. So get yourself prepared for that. That you want to be able to go in with kind of some information already, like information that we're sharing with you today, so that you're not in yourself in a state of crisis because you're so worried about not being able to do your job effectively. So this kind of walks through the various steps: noticing the crisis, choose an accessible entry, using a prepared safety plan as we're talking, thinking visually, is very important. If emergency services are needed, what are you going to do? You want to make sure that you're communicating to the next handoff what communication needs this person has. Very important to document that and have it be completely transparent so things aren't missed in the handoff, because that often can be where the problems can come up. Vince, you mentioned 988, and for many people that are with us today, they may know that 988 is accessible to a deaf person. Do you want to talk a little bit about how that is accessible so that our people on our webinar today can instruct a person effectively when they can use that particular resource?
Sure. So that's a great question. One of the things that 988 can receive a phone call from a 988, what we like to call a video phone. So if I have a video phone, it'll be like, it's kind of like, in this instance, we have Casey, who's interpreting, who then interprets to Maria, who then Maria can speak, but it's all done on our phone. And so that exchange of, if we like to call the communication triangle. So that can happen. Any deaf person can do that. There's also a group called Deaf Lead that are signed clinicians that can answer calls nationwide. We have information toward the end where we can give you that too. So again, it used to be where, for some of us older folks, we don't remember the TTY. Well, in order for, that to work, the person would have to have a TTY on either end. And that's not necessarily the case anymore. The majority of deaf people have video phones and that can use that as a mode of communication. So the TTY number is not, while it's meaningful improvement. So you don't need to worry about having a TTY or a dedicated TTY number. So that's kind of an improvement.
And
Go ahead.
also just to add to Vince's comments about 988 and Deaf Lead. Deaf Lead is the organization that will be connected automatically so that the deaf person is not interacting with a hearing person and an interpreter. They're actually interacting immediately with a person who can sign and who can start the process of talking with that deaf person. It's a really great resource. there's in some situations when we've tried it, when staff in our center have tried it, there can be a slight little delay there it is. Thank you very much for putting that up. There can be a slight delay in terms of connecting to that deaf person that is going to sign. But also, as Vince was saying, there's chat features too. Obviously, you all know 988 has chat features. But when you're deaf and you identify yourself as deaf, you're typically going to be connected with someone that can have an understanding of who you are in the 988 system. So that's pretty great. So I guess kind of is there anything else that I missed there, Vince?
No, one of the questions that came in is, do cell phones with video capability work as a video phone? And the answer is yes. So they are, so most deaf people do have their ability to take their phones with them and be able, just as hearing people can take their cell phones and go to the grocery store or whatnot, deaf people can use it. However, because it's a little bit, more bandwidth and more, Wi-Fi and cell phone, so cell phone can't be spotty. The other question that we had, Maria, and I'll ask you this question, is as a hearing individual working in suicide prevention, what would you say are the most valuable things I can do to better serve and advocate for the deaf community in general? What knowledge, skills, and changes in practice would have the greatest impact? So, and I'd be happy to answer this that came in the Q&A. For me, I think, taking this training is number one. Number two, being able to offer deaf resources like the Deaf Lead that we just shared with you just a moment ago, more deaf individuals can communicate with other deaf individuals, just as we can communicate in the hearing world with hearing people with shared language. So that's always a great way. I think those two are, and then I think for me, as a deaf person, not being afraid of using an interpreter, whether it's through a video phone or through in person, or but just so for me, as I'm working as a with deaf individuals, I don't even think about the interpreter in the sense that I allow Casey to do the communication for me. And when that breaks down, we can intervene as needed. So, Jerry, do you want to continue?
I just want to add
Sure.
to that, Vince, and Jerry, please add your comments as well. The other thing I think that is a simple thing that a hearing person can do that doesn't know sign language, pre or post interpreter, right? Or maybe the interpreter, you're waiting for the interpreter. I think some simple things that we forget as hearing people is one, slowing it down, taking a pause, but also being comfortable with yourself and your body, being comfortable with gestures, being thoughtful, and just thinking about just how do you get a person to just come over and sit down, or if they're in an agitated state, perhaps, or seemingly they're just so frustrated, just getting them just simple hand gestures to get them to pay attention, to sit down, to know that you're thinking and talking to them, to write notes to say, we're getting an interpreter. You can just write the word interpreter. You can make sure that you're looking directly at that person. Eye contact is very, very important. And just making sure that person, starting to build trust with that person just by being centered and calm, using gestures, using facial expressions, being friendly. All of those things go a very long way. If you do know sign language, if you know something, if you know hello, if you know thank you, or wait, or just simple things, those things also go a long way. But I think probably most important is just yourself being settled, and that's again probably preaching to the choir in that regard, because you're probably already doing a lot of those things, and to be trust yourself that you're already probably doing some pretty empathic kinds of interactions with that person. So, okay,
Okay,
Jeremy.
so this slide shifts the focus from individual providers to organizational responsibility. Okay, so unfortunately, many failures are predictable system problems, such as things like not having rapid access to qualified interpreters, accessible safety planning materials, or clear crisis procedures, which is kind of some of the things we're talking about, or staff trained in deaf responsive care, something that you're beginning to get right now, which is excellent. So this is so good that you're here. Organizations can respond by building an ASL fluent and deaf inclusive workforce. And each of us or all of us could consult with any of you to do that. Establish access policies before the crisis occurs. Training staff in deaf culture and language-related assessment issues, and measuring whether deaf clients actually receive timely or equivalent care. So a useful question for any organization is, if a deaf person in our community were suicidal tonight, what exactly would they be expected to do to get help? And where might that process break down? And again, some of the things we're talking about today. Don't wait for the crisis to discover that there's no clear way to get the help. And that's an important takeaway there. We've already kind of hit some of the Q&A, so we're going to skip that. We're going to go directly into a vignette. Okay. There's several slides after this that follow this individual person in different scenarios. So let's start with this. So Marcus is a fictional composite created for training. For our purposes, he's a 24-year-old Black African American deaf male whose primary language is ASL. He had limited access to fluent language early in life, and communication with his hearing family remains fairly basic. He recently lost his job, has become increasingly withdrawn, and feels disconnected from both hearing and deaf communities. During a previous emergency department visit, he was described as having limited insight and as denying suicidal thoughts. So as we follow the case, I want you to consider whether those were accurate clinical findings or conclusions shaped by inaccessible communication. Now, this is part of the scene in the ED. So his mom brings him to the emergency department because he's withdrawn, sleeping much of the day, irritable, and recently punched a wall. There's no interpreters initially available, so staff rely on written notes and gestures. Marcus gives a brief responses and is described as uncooperative. The record then states, now, limited insight and denies suicidal ideation. So the question is, was anything missed? Now, did Marcus, as you think about that, did Marcus clearly deny suicidal thoughts? Or did the communication process fail to give him a meaningful way to understand what was being asked of him and answer the questions? So that's a really important piece. And we're really emphasizing communication here because so much can get missed if that's not accounted for. Another complicating factor is once labels such as uncooperative, resistant, or whatever enter the record, later providers are going to look at that and accept them without considering whether the original assessment was accessible or there were any problems in communication. So that's it really the impact that one person can have going down the line for that deaf individual is profound and really can miss a whole lot or put things in that really weren't necessary and not accurate. Go ahead, Maria.
No, I was just going to say what we said before, that handoff. Like if there was something missed and he's already getting labeled in one direction, he doesn't have a prayer later on.
Right. Exactly. So at the outpatient visit, the clinician's questions are reasonable. As you can see there, are you depressed? Do you feel hopeless? Have you had thoughts of harming yourself? Things like that. But terms such as depressed and hopeless, they're kind of abstract and really depend on a shared clinical vocabulary that to me reflects English as a first language, a person really kind of having access to those concepts or words, where a deaf individual might not. The interpreter notices that Marcus appears confused and asks the clinician to rephrase, right? So the interpreter did notice that. Instead of relying only on labels, the clinician can ask about concrete experiences we mentioned to being concrete, and things like feeling sad most days, are they sleeping more, is the person withdrawn from people or believing that things won't improve. Questions about suicide should also be clear and direct, with one idea presented at a time, right? Being really kind of methodical in that way. And the goal is not to oversimplify the assessment. It's to make sure that Marcus understands what's being asked of him so that his answers can be interpreted accurately. So for example, are you depressed? More concrete ways of saying that, you're operationalizing these things, right? So do you cry a lot? Do you feel unhappy many days? Do things you used to like to do, you don't like to do them anymore? Do you stay in bed a lot of the time, or do you not like being around people? Again, we're kind of going through the DSM in a way and operationalizing all these things. Do you feel hopeless? A more concrete way to say that. Do you think things can get better? Yes or no? Do you feel stuck? Do you think your problems will never end and never go away? When you think about next week or next month, do you see good things or only bad things? Do you feel like nobody can help you, or nothing will get better? Instead of saying, have you had thoughts of harming yourself? And, we know that in suicide questioning, suicide prevention questioning, harming yourself is not necessarily the same thing as killing yourself. So you have to be careful about that and ask really pointed questions. But more concrete ways are, have you wished you could go to sleep and not wake up? Have you wished you could disappear? Have you thought about dying? Have you thought about hurting your body? Have you thought about killing yourself? Have you thought about how you might do that? So those are just some examples of ways to concretize and operationalize these concepts. Really important. Now, what should have happened differently? So let's kind of walk through this. First, establish effective communication through a qualified interpreter or a clinician who communicates directly in ASL. VRI, as we mentioned, it should be used only when it provides effective communication for that individual in that situation. If it's not, then you got to pause, because you're not going to get an accurate assessment. So it means you got to back up, you got to stop, you got to get an interpreter, a real live interpreter. We talk a lot about family members, and we always encourage not to use family members, particularly children, because of the emotional stress that they're under, and their perspective of not wanting to get their relative or their parent or their brother or whatever in trouble, or whatever they might think. But sometimes, that's all you have. And so you have to be really, really mindful about that, and tend to not do that, because when emotion gets involved, when different agendas are involved, you again might not get the right information. Second, complete the assessment slowly, as Maria mentioned. Clarify important terms, use again concrete follow-up questions, make questions and concepts operational, behavioral, as much as possible, and check for understanding. Always check. And what Vince mentioned, can you say what I just said back to you, back to me? Next, you need to create an accessible crisis plan that we just mentioned about. It needs to identify exactly how Marcus can contact people to help him, and who can support him. Finally, make sure that the next provider knows his communication needs and the relevant risks, so that he doesn't have to, or he or she doesn't have to start all over again. Big takeaway: improving communication can change the clinical outcome, which is really what we're trying to do.
So what questions or reaction came up for you as you considered Marcus's experience, and what could have been done differently?
Feel free to put those in the chat, and or even the question and answer. We're gonna continue to move forward just for time wise. Go ahead, Vince.
Okay. So, so preventing this type of failure is a shared responsibility. Clinicians can begin with communication access and adapt the assessment when questions are not understood. Educators can notice withdrawal or changes in belonging and know where to refer to someone for accessible help. Advocates and community members can strengthen deaf peer connections and help families improve communication. Prevention specialists can review materials and crisis procedures before an emergency occurs. The practical question in each of us is, what is one change we can make within our own roles? So this topic is not about retrofitting a hearing center model with a few accommodations. It's recognizing that language, culture, and access are part of suicide prevention itself. The question is not whether a deaf person can adapt to our system, but rather the question is whether the system is accessible and effective, is accessible and effective when the stakes are at highest.
So let's talk about some of the resources. We talked about the 988 Suicide and Crisis Lifeline. That is really, really important. As we described it briefly to you already, to know that a deaf person can access, if they have access to a video phone, and that would be a question you'd want to ask, whether it's on their phone or whether it's in their home. It's a question that you want to know if whether they have access to a video phone. If they don't, they'll have to use other means of connecting with 988 through an interpreter, and obviously 988 direct would be better. The Ohio Care Line, as we know, offers statewide emotional support. So the other resource is for young people under the age of 20. MRSS provides community-based crisis response, and it's available throughout Ohio. We recently did a training with them, so they're starting to become more aware of how they can interact more effectively. Obviously, in an immediate emergency, 911 is accessible. I think what's most important is when whoever is calling 911 for that individual, they must let dispatch know that that person is deaf or hard of hearing and has communication accommodation needs. That's critical. And again, I think you see Deaf Lead here. It's just a great resource. Just to check out the website for all of you. Just familiarize yourself with it. It is a very good resource. And so we want to encourage you to have these resources and to save them. You will get them in a link. We'd like you to save them for future reference. We also want you to contact us. If you have any questions, concerns, you want additional information. We are supported by DBH. We have a grant that provides trainings throughout the year. Our trainings tend to be a little bit longer than this. This is a drop in the bucket. We go much more into depth about deaf culture, American Sign Language, understanding languages fluency. We do a lot more in-depth training on that. Jerry is showing here our Deaf Behavioral Health Collaborative of Ohio Facebook page. It's another resource. We post videos there. There's contact information there. There's just, please join us. We would, love you to follow us. We post videos every month. This is one that you're seeing here is an individual who's on our team. There are different topics that we present. And again, we want to be a resource for you. So please feel free to reach out. I know that Emily, you wanted us to be able to take some questions.
Yes.
Some community partners there. You saw Mark Bird, oh, another thing I want to just point out, speaking of Mark Bird, who I saw there, who works for Greenleaf Family Services in Akron. We have 7 community centers for the deaf around the state of Ohio. Our community centers for the deaf, it's in our resource list, by the way. Wherever you are in Ohio, there is a community center for the deaf that you can contact. The community centers will provide you expertise in deafness and deaf culture. They can answer questions generally about where to find interpreters, where can I take ASL classes. They provide case management support, vocational rehabilitation support. Most are not affiliated with mental health facilities, but some are, and you can get information from each of them. We happen to have one in the Cleveland area. Akron has, Canton has, Youngstown. So again, across the state, our community centers for the deaf are a fabulous resource for you. Use them, and you will not be disappointed. So we now have just 4 minutes left before you all have to leave.
No worries. It was an incredible presentation. So thank you all for everything you shared. I learned so much. I hope our participants did as well. And Vince has been doing a fantastic job of actually answering some of the questions as they've come in. So we just have a few outstanding. One that it looks like we want to answer live, Vince, is about the Ohio, I believe that's Careline, is no longer active. It's been rolled into 988. I'm not sure if anybody has a perspective on that they want to share, but I wanted to just flag that.
That was my understanding. I think that was probably 2, 3 years ago that happened. But yeah, I believe that the Caroline has rolled in. I don't know if Jerry or Maria, if you have any thoughts or opinions on that.
No, but thank you for pointing that out. Whoever pointed it out, thank you. We're sorry for that glitch in our resource list. Because 988 actually has done a great job, and we hope to do some more training for the state as it relates to deaf individuals. As we mentioned, because video phone calls go directly to a deaf person, very often a person answering a call on the care line for 988 might be answering a call of a person that's calling for a deaf person. And when we do training with those that answer calls for 988, it's those kinds of things. When you're helping another person to ask the right questions versus you yourself, but also to make sure that you provide that information to the person if that deaf person they're calling for, that you are make sure that they're aware that 988 is accessible through a video phone.
Yeah, that's great. Thank you. We had a comment, I believe it's Elena. She had a lot of great feedback. Really enjoyed the presentation. She also was wondering if there are any thoughts specifically in regarding working with youth who are deaf or hard of hearing. Are there any caveats you'd want to share, anything like that?
Yeah, we did a whole presentation for MRSS on deaf youth because there are particular things to attend to for deaf youth that do kind of need a little bit more attention than we have time to provide today. A lot having to do with even more limited access to language and communication, and how to effectively use an interpreter when. Because of course, generally speaking, we want to impress on people that using family members and friends to interpret is not what we would recommend. However, when it comes to youth, there are some situations when one would need to get some information from a family member about the young person's communication and language use, that they may not form their signs properly, and a family member may know what that sign is and an interpreter may not. So there's some real complications when it comes to youth. But again, that is kind of a separate topic. But thank you for asking it. Very important. And again, little bit more complicated because of language and communication access for deaf young people versus adults.
Absolutely. All right, I think we've got time for one more question. There was a question about the experience of the deaf and hard of hearing folks who reach out to 988 and what has their experience been like? This person said, in general, the process has worked or is expected to work for like immigrants and people that speak different languages, but sometimes they're not always getting directed to the correct support. So curious if we have any feedback about what that experience has looked like for this specific community.
We haven't gotten, and Vince, if you have additional information, please share. But if we haven't gotten feedback directly from 988 itself and in terms of how they're managing, we don't get that that data. What we do have from clients that we serve, however, and individuals that have called, they've had a positive interaction with 988 thus far for those that have used it, that are deaf and have called through their video phone. That time to connect has been good. The person on the other line is well trained, is empathic, and so on and so forth. So that we've had some good experiences from people. I haven't gotten any significant negative feedback at all as of yet. But again, we may not be the people that get it. And it might be that those that are taking the calls might have better information. It hasn't, I don't know where it's publicized, to be honest. Dr. Hayes.
Yeah, I just want to emphasize and really, really invite all of you, go to our Facebook page, join our Facebook page. There's trainings. We'll post upcoming trainings. We have a new cycle. We're just going to be starting through DBH, and we're going to be all day trainings for part 1 and part 2, and we have small vignettes, as you saw when I put up the Facebook page. We would love you to be a member of the Deaf Behavioral Health Collaborative, which is really the group of those folks who want to know more about deafness and want to build their area of expertise in the area of working with deaf clients. And even if you're not a clinician, you're going to see deaf clients, you still might have, and that's why we're doing this training, find yourself in a situation where this information is going to be invaluable. And so why not join and check out different things we have coming up. So please
Great.
join.
And I will include that link, that Facebook group link in the recap email as well, so people can access it that way. And I did see some folks asking about, can we get a training for this? I will include Maria, Jerry, and Vince's emails in the recap email, so you can reach out to them directly and connect.
Absolutely. We do trainings for individual organizations as well as just generally in the state of Ohio for clinicians, but in various areas, whether it's crisis, suicide prevention, it could be for just community mental health centers. So youth versus adults, psychiatrists versus counselors, things like that.
Fantastic.
So.
All right. Well, we are over time. Thank you all for staying with us for an extra 3 minutes. As a reminder, that recap email will come out with all of the information, the slides, your survey to take to get your CE credits, a recording of this webinar, etc. And then really quick, I wanted to preview that our August webinar is going to be on August 19th at noon. And we are going to have 2 speakers that'll be sharing about older Ohioans and suicide prevention. We just had a new resource come out, a toolkit specifically built for caregivers, clinicians, community members on how to help better support the older adults in their lives. So we will go through that toolkit as well and get you all that resource. So thank you so much, Maria, Jerry, Vince, for being here today and for sharing such incredible information. And Casey, thank you for interpreting for us. We hope you all enjoyed and learned something new, and we'll see you next month. Bye, everyone.
Thank
Take care.
you.
Thanks.